name is Dr. Tony Khoury. I'm a professor of urology at the University of California-Irvine and the head of pediatric urology at the Children's Hospital of Orange County. I moved here about 9 years ago from the Hospital for Sick Children in Toronto, where I was also the chief of pediatric urology there. And in Toronto, we had a national center for bladder exstrophy. And as a result, and with the background of Dr. Bob Jeffs being, having started the program in Toronto back in the 70s, we had an outstanding experience with bladder exstrophy over the past 25, 30 years. I was asked to chat a bit about continence in the bladder exstrophy population. And I think it's important to understand continence is to understand the components and what makes a child dry. And then we can take it a step further and try and understand what are the challenges with our bladder exstrophy children. So if we think of a normal bladder and think about it as a balloon, the balloon has a container that stores the air, and then we're pinching the outlet or the neck of the balloon with our fingers to hold the air in. If I let go of my fingers, the balloon automatically, by its elasticity, contracts and the air escapes. If I'm not holding too tight, I'm going to leak some air and the balloon eventually will drain out. Same thing happens with the bladder. It's similar to the balloon. We all know that we don't need to push to urinate as opposed to having to push to have a bowel movement. Urination happens by relaxation. We relax our pelvic floor and our bladder outlet, and the urine comes out without us having to strain or push. So that's the emptying side of the equation. The storage side actually is dependent on 3 factors: the size of the bladder, the size of the container, the pressure inside the container as that container fills, and we call that in medical terms compliance, meaning a highly compliant reservoir is one that expands in capacity, increases in volume without a significant rise in pressure. That's a very easy balloon to inflate. Think of balloons you would inflate for your birthday party. There are some that you just blow gently in and they blow up very, very easily with little pressure, where there are other ones that almost need a pump to fill the balloon with air. And that would be a stiff or a poor compliance or low compliance balloon. And then the final aspect is contractility. If we have a bladder that is constantly going into spasm, that bladder will tend to leak. And that is more common in children that have neurogenic bladders from spinal cord problems, such as our spina bifida population, but not very common with our bladder exstrophy population. The biggest challenges we have with our bladder exstrophy population are the size of the bladder and the compliance of the bladder wall. And of those two, the size is the critical part. Why is size small in the bladder exstrophy population? Because of the birth defect that we have. The bladder did not start as a globular or global balloon-like structure. It started like a plate that stayed open. Behind the plate, there's the pelvic structures, and it's attached to the abdominal wall on both sides. When we close the bladder exstrophy plate, we are using some of the plate and are reducing its size even more. So we're taking a flat sheet and we're making it into a sphere. And as a result, the overall circumference of that sphere is limited by the width of the bladder plate. On average, most bladder plates when the babies are born is only about 2 inches in wide, and these are the good ones. So if that's the circumference of our balloon, 2 inches, that means the diameter of that balloon is about 1.5 centimeters. The 5 centimeter circumference or 2 inch circumference becomes under 1 inch in diameter. And you can imagine how tight and small that is. It's about the size of a thimble. However, because it's a biological organ, it has the ability to grow with time as it's cycled and stretched. Now, When we first close the bladder, we're very concerned about how much pressure we can place in it. And so we allow it to leak at low pressure. And we're hoping that over the next 2 to 3 years, as the children grow, the bladder will cycle at low pressure and grow with them. However, many a time that bladder leaks at such a low pressure that it doesn't have a chance to hold any urine in it. Now, you've all heard the magic number that we need to achieve a capacity of 3 ounces, 100 milliliters, for us to be able to move on to the second stage of the reconstruction, where we do the bladder neck reconstruction and try and gain continence. If that bladder doesn't have enough resistance at the outlet, at the neck of the balloon, if it's wide open, that balloon will never distend. And if the balloon never distends, the size and the capacity of that bladder will never increase. And that's the biggest challenge we have with our bladder exstrophy population, is that we don't achieve that size that is required for the child to be able to hold enough urine in there to have social continence and enough dry interval to be able to have a normal, reasonable day at school where they can be dry for 3-4 hours before they need to go empty the bladder again. The second and also very important challenge is constructing the outlet. Now, if we think of the sphincter, a normal bladder sphincter is adaptive and is active, meaning that as the pressure inside the bladder increases, that sphincter tightens and tightens and tightens and increases the pressure, just like I would around the neck of a balloon when it's getting really full. The bladder outlet, so-called sphincter or bladder neck reconstruction that we can build in surgery for these children, unfortunately, is a fixed resistance. So I can only offer a narrowing of the outlet that is fixed. So for the child to urinate through that, the child has to push to allow, because that sphincter does not naturally relax. So the child has to push in order to be able to expel the urine. As a result, we have to be very lucky to achieve that right amount of outlet resistance that makes the child completely dry, but yet is able to allow the child to urinate through by straining without having to create too much pressure to urinate. And that's a very, very fine balance. And that's one of the main reasons why many of these children aren't able to achieve that complete dryness. Now, the other complicating factor is when we look at under the microscope at the histology of the bladder neck area in children with bladder exstrophy after they've had the staged approach, and we take some biopsies from the edges of the bladder neck just before we reconstruct it and stain it for fibrous tissue, we find that there's very dense fibrous tissue on both ends of that. So it's like taking a block of cement and hoping that you can achieve a pliable contracting outlet out of that. So the amount of resistance that we have to offer has to be just right. And B, the tissue that we're trying to offer that amount of resistance with is not normal, elastic, healthy tissue. It's tissue that's been operated on prior and that has been exposed as part of the bladder exstrophy defect, has been open to the amniotic fluid and to the air, and therefore is not ideal and perfect tissue to use for the reconstruction. So when we put all this together, we say, okay, so we have issues with the storage compartment of this reservoir, of this bladder, and we have issues with the outlet resistance of this bladder. No wonder many of our children continue to struggle with issues of continence. So that's the sort of big picture of how, why these children are wet. Now, what can we do about it? And so Many a times when the bladders have not grown to sufficient capacity to allow the children those dry intervals, these are the children that end up with a bladder augmentation or enlargement of the bladder. And we try to avoid that as best as possible, simply because enlarging the bladder carries with it the current mechanisms that we can use to enlarge the bladder today are using intestine, mostly small intestine. And intestine is designed to absorb. It has a lining that is absorptive. So when it comes in contact with urine, it ends up absorbing some of that urine back into the circulation, or some of the acids and metabolites excreted in that urine back into the circulation, which taxes the kidneys again. Now, in general, that's not a big deal if one has healthy kidneys. They have enough reserve that